Hello everyone. Thank you again for joining for our Rafael Medina subspecialty VMR. And we are really excited to have Dr. Tepper and Raji Govalan to join us and present the case as well as could discuss the case. Dr. Tepper is going to be discussing and Raji is going to be presenting. And I am going to pass the mic. And we do have also Julian and Magnus from the Academy who have been really kind enough to sign up for the TP and the scribing. So I'm going to pass the mic to Dr. Tepper to introduce himself. Dr. Tepper.
Hey, it's great to be back with you. It's CP Solver. I'm Elliot Tapper, hepatologist at the University of Michigan, where I spend my days caring about and caring for people with chronic liver disease.
Perfect.
Awesome.
Hi, everybody. I'm Raji Gopalan, one of the third-year GI fellows going into hepatology. I'm the lucky kiddo that walks into a candy shop every single day, surrounded by all these legends, too hard to pick up which candy I love the most. So once again, honored to be here.
Awesome. Magnus and Julian, did you guys want to say hello?
Hello everyone, my name is Magnus. I'm from Denmark. Super excited for the case.
Hi, I'm Jillian. I'm here in New York, also excited to hear the case and discussion today.
Amazing. And I like starting our session with an icebreaker question. And recently, if you guys have been following Dr. Tepper on his Twitter, you would have noticed that he's been sharing amazing pictures from his trip to Kolkata. And I am currently in India and Chennai, and I always have a very sweet spot for Kolkata because the City of Joy, the book which is based off Calcutta, is amazing, and that's what got me into reading. And Dr. Tepper, did you want to share any your pearls from your recent meeting which you had in Kolkata? And what was your favorite food over there?
Oh, well, I had the privilege of being invited by Akash Roy to the Bengal Liver Summit, and it was a terrific meeting. And in fact, like India is leading the world in clinical trials focused on the management of complex cirrhosis. And one of the coolest trials I was able to describe was by my friend Dr. Nipun Verma, who's randomizing patients with cirrhosis to growth hormone injections and observing massive improvements in function and quality of life. In Kolkata is also the city of sweets, and I overdosed on dessert. Having multiple rounds, I might have insulin resistance now, but I'm very happy for the experience.
So, and Raji, are you also originally from India, or did you have any ties to back to India?
Oh, absolutely. I was born and brought up there. I only moved here in 2010 or so. So I'm from southern India, so definitely a huge foodie. And my mom, talking about insulin resistance, my mom just sent us a huge package of goods and snacks from India. So I'm pretty sure I'm getting slowly closer to Masold, but hopefully I can catch it.
That never dies. That's never, I mean, like I just told my mom, she say whatever sweets she cooks, and if I like it, it's been, packaged and kept in the freezer for me to have it. So each day, one thing or two things come out, and it's interesting. So whenever we are ready, Jillian, did you want to share your screen? And Raji, are you ready to share your case?
Absolutely. Okay, so this case is going to be from the perspective of us humble GI fellows who rotate through hepatology and is always amazed by the complex cases that come through. It's yet another 4:30 p.m. Friday consult. You get a page saying elevated liver enzymes, and then you look at your co-fellow. Is this dilly? Is this something else? Should it be a 4:30 p.m. consult? But you call back, and there is the ICU. They tell you, hey, we just got a 20-year-old female with a history of recurrent seizures, also depression and suicidal ideations in the past, who was transferred from an outside hospital after she had tonic-clonic seizures. Do you want me to give the rest of the HBI as well?
Dr. Tapper, did you want to share what's really going on in your mind if you had a GI consult after a person had a seizure and coming with elevated liver enzyme, or do you think they're not related?
Well, so I think there's a few things that come in mind. First, I got a phone call from the ICU. So I'm imagining that we're going to be dealing with some high levels of liver enzymes. And then once I hear about 20 years old, I hear about mental health history, I hear about seizures, I immediately leap to my concern for a toxic ingestion, including but not limited to paracetamol, acetaminophen. And that's going to be number one on my differential. And seizures probably as a secondary is sort of secondary and supporting whatever the potential drug toxidrome might be. But there's a couple of wrinkles that seizures will bring up, right? One is this a consequence of progression of the liver disease, whereby the patient developed severe hyponatremia? That's one. Two, when somebody seizes, depending on how long it's been going on or how long they were found down, there could also be muscle injury and rhabdomyolysis, mimicking the presence of severe acute liver injury. And when you seize, your muscles are undergoing profound anaerobic glycolysis, and if you happen to check an ammonia level on a patient like this, you will think that they're in full-on liver failure. You can get sky high ammonia levels from seizing, and then if they already have a seizure disorder, they might be on valproic acid, which also increases ammonia levels. So we're already at the setup for something that could be that could lead us down the path to a diagnosis or a bunch of red herrings. Either way, the game is afoot.
Perfect. To shed a little bit more light on how long she has been found down. So basically, she has going through a lot of psychosocial issues, recently moved in with her parents just a day ago. And per her mom's history, she's been sleeping the entire day the previous day, not even coming down to eat. So mom was very worried. So she went upstairs to call her down for lunch. And that's when she found this tonic-clonic seizures. Mom freaked out, called EMS. EMS came in. The seizure episode lasted about 3 minutes or so. The EMS came in, evaluated her, but then had another episode of generalized tonic-clonic seizures. It's been witnessed by the EMS and had this post-ictal state after. She was found to have stable vitals. Heart rate is around 115, but blood pressure is in the 110 over 87. And then her oxygen saturation was in the 80s. Given concern of hypoxia as well as airway protection, she got intubated and sedated and transferred to a local hospital.
This sounds a lot more acute, and then we also understand why she's now in the ICU. And Dr. Tepper, when you get some information like this, are you prioritizing it's all to do with rhabdomyolysis probably, or do you think there's more going on? Or what exactly are you thinking of, or what did you want to know further, I mean, in terms of, help you understand how to manage it?
Well, I think the first thing to keep in mind here is A, B, and C. And this is somebody who's in respiratory distress. They're not able to maintain their mentation. And as proud as I am to be a hepatologist, as important as the liver might be, it is also more often than not a bystander when it comes to severe liver injury. And I might hear about a very high liver enzyme, but I'm also stuck with the idea that there could be a toxic ingestion, and then along the way, this person who had a period of apnea, hypoxia, now probably some aspiration, making things worse, found down, potential rhabdo. I'm thinking outside the liver for the potential causes of acute liver injury, and I'm grateful to my colleagues in the ICU to help stabilize her. I'm there to put notes in the chart for patients with liver injury, but I'm not worried right now about something that's a primary liver process based on the history alone.
Perfect. Giving a little bit more about rounding up the history part, we talked about depression and seizures. She also has obesity with a BMI of 40 and has prior episodes of suicide attempts with TCA overdose. With regards to medications, currently except lamotrigine and fluoxetine, she's not on any other medications. No other family history that's pertinent, no other social history that's pertinent, and no known allergies as far as what we know. Moving on to the physical exam part of it, she's afebrile as of this moment. We talked about the rest of the vitals. Otherwise, she's intubated and sedated, very limited history that we can get, or no other prominent physical findings either.
Maybe I'll just stop by saying a couple of pearls here. When you're listing the medication list, I have in my mind a Rolodex of known offenders to cause liver injury, either idiosyncratic or direct. And sometimes the medicines that the house staff tell me about are things I have never heard of because each and every day something new is out there to treat depression and cardiovascular disease. So how am I to determine whether or not this is a potential culprit in liver injury? And there, I would always turn to hepatology's Google, livertox.nih.gov. I put in the names of the medication list to see if anybody else has reported liver injury and what potentially the pattern of that liver injury might be. And I will be doing this in clinic with the patients sometimes. So I just want to stop us for a moment and say, this is my usual approach. Now, the classic medications that are going to cause liver injury are antibiotics, anti-tubercular medicines, and anti-epileptic medications. Now, I don't actually know if lamotrigine does this, right? But it's on that list of the classic medications. Fluoxetine, I've met a million people on fluoxetine. I may have said potentially one day it was the cause. I would want to know how long were you on it, right? Was the dose recently increased? And the other pearl that I'll mention, one of the risk factors for new drug-induced liver injury, we think is comorbid liver disease. And so this is a person with obesity who almost certainly has MASLD, metabolic dysfunction associated steatotic liver disease, which is without a doubt a risk factor for drug-induced liver injury.
Perfect. Now, moving on to the most important part is more objective data when it comes to labs. Her CBC, her first WBC was 4.1 K, but on repeat it dropped down to 3.1. Hemoglobin was 8.1, MCV was 96, platelets was 135. When it comes to her chem panel, her sodium was 144, potassium 4.2, chloride 106, bicarb of 18, BUN of 44. Creatinine, her baseline a couple of years ago was 0.5, but now it was 2 on presentation and 4.6 on repeat check. Her glucose was 106. The AST upon presentation to the outside hospital was in the 2,500 range, but now at our hospital it's 4,000. ALT was in the 600 range, now it's in the 800s. Alphos around 258, T-Bully of 0.9, and albumin of 2.4. INR was 1, pH was 7, lactate of 12, and she's quickly started on CRRT given profound acidosis, and poison control was contacted and they recommended NAC, fomepizole, and activated charcoal for concern of toxic ingestion.
Wow. So there's a lot of stuff to go down, and rather than get bogged down in some rabbit holes, I'll just say a few things, right? One is hemoglobin of 8.1. This has been going on for a while. Two is creatinine of 4.5 from a baseline of 0.5 and from 2 while we're watching her. This is somebody with no GFR like that over the course of a few days. And then we see this sky high liver enzyme level. So the AST is over the ALT, and it's in a ratio of 2 to 1, right? And we know that that's the classic ratio for alcohol-associated hepatitis, is it not? You will never see alcohol-associated hepatitis with this sky-high level of AST, even though the ratio is 2 to 1. And you might say, well, if the AST is higher than the ALT, then this implicates the muscle. And it might. But once you start going up into crazy high levels, just the fact that you have more AST than ALT does not tell you anything about the source of the liver enzymes. And then I see an alk phos of 258, and I know without a doubt that there might be muscle contribution. There is certainly liver contribution. And then I see the bilirubin of 0.7 and an INR of 1. and all of a sudden the hepatologist in me, my blood pressure goes down. My heart rate is what started out way higher than 115, and then now it's way lower because I know this liver is rock solid. I know this liver is upset about something. We got to figure out what it is. However, my prognostication vis-a-vis the development of acute liver failure is there. So key point, this is not acute liver failure. There is no increase in the INR despite the fact that she is encephalopathic. Okay? There's something is definitely up, but it is not acute liver failure. Can we also talk briefly about the cocktail of drugs that she's got? So activated charcoal, that's cool. It's old school, like bind up some of the medicines to prevent absorption. I like that. The NAC, you guys know. You guys know where the NAC is for. The NAC is for the acetaminophen toxicity. But what's the deal with famepizole? Famepizole means that this toxicology consultant is in the know. Okay, so we all know that acetaminophen causes liver injury because it gets chewed up, and it chews up all of the glutathione. And once the glutathione is taken care of, the drug is metabolized by a cytochrome system that creates that NAPQI. Okay, NAPQI. I don't know what's the in vogue pronunciation of that term. And it's the NAPQI that goes ahead and jacks that liver up. So famepizole, okay, famepizole inhibits that cytochrome enzyme and prevents the formation of the development of that toxic enzyme. And so for people where the acetaminophen level is undetectable, who are in the active phase of liver injury, there's some evidence, though no randomized trials that I'm aware of, that famepizole is an adjunctive therapy that prevents the progression of liver disease. So I'm totally cool with this. This sounds like great, like when you're shooting in the dark for something, you want to do something. This is like a safe option. The question is raised, why the lactate? I got no clue, but I mean, the seizure can do it, man. Right? So you get that sort of that it's not an ischemic lactate, right? It's just that you're generating it from the muscle shivering, or it could be the drug itself, which is poison mitochondria. Time will tell.
Perfect. We also have one other lab that was done initially, which is LDH of 10,800.
So somebody old, gray hair, okay, probably a bow tie, would tell you that the LDH of 10,000, this implicates ischemic hepatitis. You should check that's poppycock, okay? LDH of 10,000, this liver and something got jacked. That's all we need to know here, right? So ischemic, like we didn't talk about the differential for the ALT, and we can definitely do that depending on how you guys want to go. But like if you told me the LDH is 10,000 or if it's 400, that wouldn't matter to me at all. The test characteristics of LDH mean nothing for the differential of sky-high liver enzymes. Should I talk about the standard differential for sky-high liver enzymes? Okay.
Yeah.
So when Dr. Govilan gets called, the first thing she does is she says, you should check an alpha-1 antitrypsin and a ceruloplasmin and a ferritin, right? That was information passed down from on high to all GI fellows to write in every single note. But instead, what I need you guys to know is that the differential diagnosis of a sky-high liver enzymes is this. Number one, ischemic hepatitis. Okay, now this is a person who could have ischemic hepatitis, right? First of all, they were hypoxic. Secondly, most people with ischemic hepatitis are not systemically hypotensive. Ischemic hepatitis is really just about perfusion of the liver. And most people with ischemic hepatitis have right heart failure, which is interfering with sinusoidal flow. Okay. So the vast majority, if not 90% of people with ischemic hepatitis have right heart failure. So 90% of the time, I'm right every time when I recommend either checking their pressures when they have their central line or getting an echocardiogram. Number 3 on the list is drugs, and drugs including acetaminophen. And what's number 2? Number 2 has no blood test. Number 2 for sky-high liver enzymes is choledocholithiasis. which probably causes an ischemic injury to the liver when it acutely obstructs the common bile duct. And number four is going to be acute viral hepatitis. So if you're practicing in an area where like you see a lot of intravenous drug use, you can see like new episodes of viral hepatitis. If you're practicing in an area where hepatitis A is rip roaring, and that happened in Michigan a few years ago, that's gonna rise up the chart. Um, the word ischemic hepatitis, it just has to do with the delivery of blood across the hepatic sinusoid. And the reason why it's ischemic is not, so you're not a supply side economist, okay? You're not in the Reagan cabinet. You have to think not only about delivery of the blood to the liver, but exit of the blood from the liver. And if the blood cannot exit from the liver because there's a traffic jam on the way to the heart, then the pressure required to perfuse the hepatic sinusoid it cannot be mounted. There's no pump between the gut and the liver. There is only the heart. So if the right atrial pressure is 10 and the portal venous pressure, right, is 0 to 5, how do you expect the blood to perfuse the sinusoid? And that's why it's ischemic hepatitis, okay? And it is never Wilson disease. It is never Wilson disease. And if you are worried about Wilson disease, and you can be in a patient who's age 20, the only way you're going to diagnose this is with a liver biopsy, which you can definitely consider once the dust settles. But a ceruloplasmin is going to be low in almost 90% of the cases, and guidelines recommend against testing ceruloplasmin in this case. And if she had cholestasis, then she could have a high urine copper. So you keep it in your back pocket, but there's no treatment right now. So we got to support this person who's in a jam. Okay. Any other questions about the differential diagnosis?
Dr. Tepper, how are you processing the ratio difference? Or is that like, is it going to be a little later on when you're going to be concerned
You're talking
about
about the AST ALT?
Yes.
Yeah, so I mentioned this up top. Once you get crazy high, the ratio doesn't mean anything to me. Okay, so even though it's like 2 to 1 AST ALT, and you start to think like, oh, could there be a muscle contribution to this or something? You forget about it. Forget about it. Once this all this means to me is that liver got punched hard, right? And the fact that the AST is high, I don't know. You know, there's no rhyme or reason to this. But like I said, she's in a jam. That's it.
Did you have a cutoff before I stop worrying about the ratios? Like as an
Huh?
R2, when I'm seeing a patient, do I have to have a cutoff like before I say it's just the whole liver in general? And then like it's like 1,000, 2,000, or did you
You
have?
know, no, so like I mean at this level, like if I'm worried about rhabdo being the main contributor, then I go ahead and like I did this in clinic yesterday. I ordered a CK for a mildly elevated liver enzymes because I was worried that this person also had some myopathy. In this case, CK would be fine. Aldolase might be a little bit more sensitive, but like at this level, the CK should be off the charts, right? And this person also has kidney injury, right? And so kidney injury speaks to the chronicity of the illness, the toxin, maybe prior ischemia or hypotension, and the potential for rhabdomyolysis.
Thank you for clarifying. Raji, I think we are excited for the next report.
Yes. So given you really, really wanted the CK, we'll give you the CK. It's 1,254. And also we have a UA, and that showed blood of 250 micro units per microliter, but the RBCs was 0 to 2. WBC was 3 to 5. Specific gravity was 1.023. Factor 5 was measured. It's 123%. And everybody was so far thinking about toxicology, but unfortunately the Tylenol level was normal, salicylate was normal, the ethanol level was normal, the PET was also normal, and the entire urine drug screen was normal, and ammonia was normal. And in terms of the chronic liver disease workup, the acute and chronic Hep B and C was negative, Hep A was negative, autoimmune was also checked, ANA, ASMA, AMA, immunoglobulins were all negative. We did not recommend it, but the ICU team ordered the ceruloplasmin was negative, and the ferritin was elevated. And they also ordered a hemochromatosis mutation panel, which was negative. And the ultrasound, I know. And the ultrasound, basically $1 million, $1 billion workup for this patient. But the ultrasound with Dopplers were negative. CT chest showed some pulmonary edema, concern for some pneumonia with consolidations. Abdomen pelvis was completely unremarkable. Off note, the CT chest abdomen pelvis was done because the patient mounted a fever on the second and the third day. So they wanted to rule out infectious etiologies.
Yeah. So there's a few things. The factor five is like we didn't need that at all because we knew the INR was normal, but factor five is like INR will tell you about the coagulation production of the liver to some degree, and they will measure it over the course of a day. And then factor five is much more sensitive. So if I just transplanted somebody and I need to know is the liver functioning like within the last hour, factor five is my test. And so in a large transplant facility, you're going to get that level back real fast, and 123%, like we're good to go, right? The ammonia level being normal, like I don't hate it, but I wasn't worried about liver failure here. But ammonia level is good if you think about acute liver failure because a high level is associated with cerebral herniation. Okay. And then if you're going to worry about acute viral hepatitis, because really that's what this question is, it's not about chronic viral hepatitis. The way that you rule this out is by getting the PCR tests, right? So the antibodies, who knows what's going to happen here? The antigens, we need the PCR tests. Checking a ferritin in this case is fully bananas because hemochromatosis cannot cause an acute liver injury. And ferritin is an acute phase reactant. And responding to an elevated ferritin by checking hemochromatosis mutations is like levels upon levels of bananery. Okay. So the baseline prevalence of hemochromatosis mutations in the United States is about 1 in 200. But even if this person had hemochromatosis, it had nothing to do with anything. So you got to take care of the patients. And it's very easy to click those boxes, but it's harder to remember. We got to go to the bedside, find out, does she have cool and clammy legs? Is this cardiogenic shock, a cold cardiogenic shock, which can happen with normal pressures, right? Do I have to search her bags for these drugs and that sort of thing? And the Tylenol level being normal or negative is expected, right? Because if this was a Tylenol overdose where the person showed up with 2 days without any GFR, that Tylenol is out of the system, right? And so that's why I said the NAC, that's fine, okay? There's actually a randomized trial from the United Kingdom where patients got NAC after their Tylenol level was negative, and it was associated with, wait for it, improved survival. This is a trial of 40 people. So giving that NAC ain't hurting anybody. And then that's where that fameprazole was coming in to reduce the NAPK formation. So far, no answers.
Okay. Now, the ICU team is repeatedly paging the GI team every single day because they're doing everything in their power to keep the patient stable hemodynamically, but then the liver enzymes are going in the wrong direction. Now, the AST is all the way up to 6,000, and the ALT is in the 900s, and the alk phos and the bilirubin remain pretty much stable in the normal levels. They're like, oh, you guys said it's toxic ingestion, Tylenol related. It's been 4 or 5 days. She's on this IV NAC and all of the treatment, but still the enzymes are not coming down. Hence, we did this $1 million workup, and all of them has been negative. What do we do next?
Yeah. So this is like you're talking about being in the candy factory. Sometimes when I'm rounding at the I'm like, I remember training in a great place, and then I show up at the University of Michigan, and then every patient just brings the heat. And so it's like it's really just remarkable how complicated people are. And like we could tell a great story, but time is often the greatest arbiter of how good our stories might be. And you always have to abandon your priors if the patient is not behaving in the way that you predicted, and you have to be humble about this. So at this point, with escalating liver enzymes, we still have roughly the same like differential diagnosis, which is like unknown toxin, right, causing progressive liver injury, right? And then we still have the ischemic hepatitis playing a role because we haven't fully excluded that right heart dysfunction that I was referring to. Meanwhile, you're doing these things that involve fluid shifts, right? Like you're sticking her for dialysis, you're giving all this NAC and that sort of thing. And so we're still in the same place. And I would really want to come together to make sure that we're our central hemodynamics are stable. That would be one. I think that would be important to me. Do I think that we're dealing with like uncontrolled choledocholithiasis? Seems unlikely, right? But it does feel like we've definitely missed something. And a lot of people have been interested in the role of a liver biopsy, okay? And I think that like that's not an unreasonable thought. But what you have to keep in mind is that this is a person with a very high lactate, with a very high AST, uh, and and remember what I told you. The liver is often a bystander, and so now we have to start thinking about, well, what can make somebody, very sick, and what can cause a high level of glycolytic activity, and the biopsy might be helpful. It might be that they have that there's lymphoma, in the liver, right? And so I start thinking that this could either just be the evidence of ongoing acidosis, which is interfering with metabolism, and and that there could be intrahepatic or extrahepatic lymphoma present. So I'd be worried about that. I'd be worried about the ischemia, and I'd still be worried about the drug-induced liver injury. So, what else? Is there anything else worth discussing?
In the chat, there are people asking, would it be a time when you're considering a liver biopsy, or is it too early for that?
Like so the so liver like I said, like liver biopsy is like a reasonable thing, but like is this person even stable for liver biopsy? So what would I be looking for on this liver biopsy, right? So if you want to say it's a primary liver process, then really at this point, like all we're talking about is autoimmune hepatitis, right? And this isn't going to get better with prednisone, right? This is either going to if it's autoimmune hepatitis, it's either going to chill out, and or it's going to progress through liver failure, and she's going to get transplanted. That's how we're going to treat it. The second thing would be like it's an infiltrative process, but like, is this going to change I mean, it's going to might provide more diagnostic certainty, right? But I'm not sure it's going to necessarily change the management. And so I would say the risk of a liver biopsy here is really quite profound. And so I would be hoping that the supportive care, the CRT, et cetera, and the antibiotics are going to help us get to a place where we can ask that question. Is biopsy appropriate? But right now, I'm too nervous.
Agreed, because we're going to crank up the heat a little bit more. It's 3 a.m. in the morning. The overnight fellow gets called. Now the patient's even more unstable, now requiring pressors, but they have black tarry output coming out. And initially, everybody thought it was related to activated charcoal. The ICU team was like, no, it's too late. He received activated charcoal way ahead. And then the OG tube started putting out bloody output. So now, time for urgent overnight endoscopy. The patient undergoes a bedside endoscopy, but it's just filled with a lot of old blood with like no poor visualization. So like, okay, keep the patient intubated, continue the care. Let's do a repeat endoscopy the next day. Does this change anything, Dr. Tapper?
So like if we were on call that night and then you just called me and said, we got to do this procedure, the answer is yes. Like we have to do this. We got to take a look. It's unfortunate that we weren't able to visualize any potential source, but like with my years of experience, a sick person, right? They could have ischemic injury to their gut just at the same time that they have ischemic injury to their liver. And a very sick person with sepsis, et cetera, will also have microvascular dysfunction. You get a really ratty stomach and duodenum, and like ulcers and erosions can be quite substantial. So like this is a person I'm going to give her a PPI, right? I'm definitely going to now I've done the endoscopy. I'm going to do it again. Like maybe we're going to talk about giving erythromycin, right? Or like some Reglan, metoclopramide to try to clear that stomach. But like The bleeding doesn't t tip me off to an underlying cause for this at all. It also feels like this is just evidence of progressive, like her Apache score is going up. Like this is sicker and sicker, and the amount of stuff that we need to do to support is fine. The INR being normal, the factor V being normal, this is not coagulopathy causing oozing at all. And then just one comment is that just so you know, like the person has a liver injury, they don't have a known liver disease, they do not have cirrhosis, they do not have ascites. By no means will this ever be called hepatorenal syndrome. So she might have like cardiorenal syndrome if this is heart failure. She definitely has set up for ATN, but this is the nomenclature of hepatorenal syndrome is exclusive to people with the pathophysiology of portal hypertension and ascites. Okay, so I'm sad that we couldn't help her with that endoscopy, but it was definitely worth a shot.
But the next day, Dr. Tapper comes on service, let's say, and then he gives all the Reglan and erythromycin, and we repeat the endoscopy, and then this is what we see. Do you want to share the endoscopy pictures? So this was unique. Like we saw, we were expecting gastric ulcers from being in the ICU or critical illness or duodenum being boggy, but then we see these punched out cratered esophageal ulcers with heaped up margins. And the next slide, we also see, as expected, gastric ulcerations that are Forest 3, which just means that there is nothing to treat with endoscopy. Medical treatment is equivalent. So we say, okay, continue the PPI and then continue your supportive care. He receives multiple blood transfusions and his bleeding slows down, and hemodynamically, we're able to wean off of his pressors.
So So the can you go back to the setup so we were about the testing and so the testing that was done, if you click on that first slide there, the testing that was done included hepatitis A, B, C, EBV, and CMV, and I'm assuming these are the antibodies, right? And so the first of all, like EBV never causes this, right? But what does cause this from time to time is HSV, and and I'm not even sure I would trust the antibody, right? But I'd be interested in the PCR. And HSV hepatitis, which I think I have seen once in the since I was in training, is exceptionally rare. You don't go screening for it, but like at this point when we're just sitting on our hands, we're not sure what to do. Like if you told me you checked an HSV, like I would say like that's a great idea. And then EBV, you're just triggering me. Ceruloplasmin, you're causing splenic infarction. Ferritin, what? But HSV for real. And when you see those ulcers in the esophagus, there's nothing pathognomonic about that. But if you're not thinking about a herpes virus or herpes viridae family, then you are not thinking correctly. So CMV 100%. That ulcer in the stomach, it definitely looked like a classic ulcer of severe disease where you just get an erosion from just being sick. Like you can have that ulcer, and anybody can have that ulcer, but the ulcer also looks like a herpes virus, like CMV or HSV, in which case I am thinking about the PCR tests. I definitely didn't think about HSV because, I'm so sparing in my testing and I would have discounted it. But here this is what I'm saying about staying humble. If I saw that, I would go right back to the drawing board and think, am I missing this viral infection?
Absolutely. Meanwhile, rest of his infectious workup, including HIV, fungal cultures, respiratory viral panel, blood cultures, all come back negative. His respiratory cultures, though, came back positive for Stenotrophomonas multifilia, so he gets treated for that. His vent requirements are slowly coming down. The HSV IgG was negative. The PCR is still cooking.
Yeah. So, yeah, I'm glad vent requirements are coming down. the stenotrophomonas, like I don't know what to make of that, but like when she was down, she was just inhaling all the junk from her mouth. And so like I fully buy that there's an infection that's making everything worse. But and again, like I definitely think that the HSV being the IgG being negative, it doesn't help me. If I saw like ulcers like that, if I had a prior hit, if I had something else like other mucocutaneous ulcers, and then if you told me you're like I need to do something, and you want to try like acyclovir off the empirically, I wouldn't hate that. Like, does that help with outcomes? I don't know, but now we're like 48 hours into this business, and we're all worried. And of the interventions on the table that might bend the natural history of this, that's up there.
Dr. Tepper, I have one question. Since we have HSV as a very high, you're considering it and you're thinking, would it be a good time to empirically start treating, or would you still want to have the lab result before you start the treatment?
Yeah, I mean, I would be okay with empirically treating, right? Yeah, I just think that empirically treating somebody with a cyclovir because they have hepatitis and herpes can cause it, that would have been a mistake. But the game has changed. We have so many negative tests. We have some credible associations with herpes virus, right? The ulcers that we just saw. And so I think, well, I think we're going to ask the question, PCR, but it's okay to take a shot.
And the rest of the team, by now, like almost all of the consult teams are on board, including infectious disease, immunology, like GI, nephrology, etc. And definitely infectious disease wanted to get an MRI of the brain because they were also considering HSV. MRI of the brain was completely unremarkable. They attempt to do an LP, but then given the body habitus, they were not able to do the LP. Still, the PCR is pending. What are your thoughts at this point, Dr. Tapper?
Yeah, I mean, this you have to think about the limitations of some of these tests, right? I have no clue why we would get an MRI of the brain. Like why would I send this person off the floor for an hour for this test, right? If you're worried about herniation from the LP because of whatever's going on, like there's bedside head CTs where that would be sufficient. The LP is also reasonable to make a diagnosis. But don't forget, like what we're observing is outside the cerebrospinal compartment. So like I would just take the serum. There was a question about like why didn't we biopsy the lesions? Why not? Like if like there's nothing stopping you from biopsying at the ulcer base for these things, and I don't blame the on-call endoscopist for not having done that in this spicy situation in the ICU, but I would say like in retrospect, like if I were to see that, I would if I wasn't prepared to just shoot and start treating, I would probably biopsy because that's the closest we could get to a diagnosis. Yeah.
Yep, agreed. The on-call endoscopist was worried about like downtrending hemoglobin, being on pressors, etc., and already like overt bleeding. So they didn't want to cause even more bleeding that would confound the picture. And they said, let's go ahead and empirically start acyclovir. And finally, the HSV PCR came back as undetectably high, 10 million copies plus. And over time, anything else, like once we have this one, the HSV is definitely everything is pointing towards HSV. Do you think that's the only thing that's causing all this liver enzyme and all this chaos?
I think that we have very strong footing on which to say that this is worth treating. Now, does it explain everything? Like we wanted to get an MRI and we wanted to do an LP because we were worried about meningoencephalitis. Don't forget, this is a person that came in with seizures. Okay, so now we have an explanation for not only the seizures, the hepatitis, and then the mucocutaneous ulcers that we observed. We have some very strong data here. Now, HSV hepatitis, which hasn't rocked the INR yet, like for it to explain the lactate is pretty, that would be pretty weird. So then I have to start telling a mixed story about how the lactate was caused primarily by the seizures and the hypoxia, and which were all superimposed upon this. So there are several processes at play for which this person requires like a longer discussion on rounds. But I do not believe that the HSV can explain every single thing, but it definitely explains a lot.
Awesome. And then how was the patient doing after this, Raji? And what was the final diagnosis and how did your team manage this patient?
Absolutely. So similar to Dr. Tapper's verdict, we were also thinking about, is it just the Hickam dictum or is it like Hawkins razor, like one thing, many thing? And we erred on the side of multiple things causing the liver injury, the seizures, and maybe the seizure-induced rhabdo that kind of contributed to further the AST elevation that was so high. And another thing that the teams did is why this person, it's a 20-year-old female, not immunocompromised. Mostly we see HSV, disseminated HSV. We see HSV hepatitis or oral lesions or ulcerations commonly in immunocompetent people, but disseminated HSV, mostly immunocompromised. So now the team was looking towards what could be causing immunocompromise in this 20-year-old female. They consulted immunology. Immunology, once again, did $1 million workup with all these genetic analysis, and they came up with this mutation, the INVITE panel that looked at some genetic variation called SAMHD1, which basically reduces your ability to protect against viral infections. So maybe true, but maybe theoretical. But currently, the running theory is that this patient did not have a great immune system because of this genetic mutation, got exposed to HSV infection, that became disseminated, had this HSV esophagitis and encephalitis, leading to seizures. The MRI of the brain was mainly done to see if there is any temporal changes related to this HSV so that they can pin their diagnosis on HSV encephalitis. But early on, based on like our reading, you might not see any manifestations on brain MRI for HSV encephalitis. That's why you need an LP so that you can look at the sterile sample and look to see if there is any viremia and inclusion bodies in there on staining. But unfortunately, we weren't able to get that. So overall theory is that patient maybe got a double, if not a triple hit, where HSV encephalitis led to seizures, led to rhabdo, injured her kidney. That can explain the UA being positive for heme, but not RBCs, and then all the renal failure leading to that. And then also had this severe esophagitis involvement. And maybe there was some ischemic component related to that, that overall, once you stabilize the patient, supported him in every possible avenue, including the GI bleed, his liver enzymes started responding. Maybe it's the acyclovir, nobody knows. But with this multidisciplinary kind of putting all of our thoughts together, supporting him in every single possible way, his liver enzymes started improving. And now the most recent liver enzyme was AST in the 50s, ALT normalized. His real hospital course is even more complicated because he developed critical illness pancreatitis. He has fluid collections. Now he is compressing on his biliary system. Now his alk phos is off the roof and T-bili is off the roof. But that's for a different morning report. This one, let's stop right here.
Amazing case. Dr. Tepper, do you have any final thoughts?
Yeah, so that got tied up in a bow, and doesn't always happen this way. And Dr. Govalan definitely chose wisely, wisely in a number of ways. Reminding us how wild inpatient hepatology consults can be. Reminding you that to keep your differential broad, even if you are known for being a conservative tester like myself, like it's totally reasonable to not go looking for HSV with everybody. But after a day or so, if you're still dealing with this, when you get reconsulted, don't have your backup to say this was what we said and therefore it is true, to rethink things, because this is definitely on the differential. If it's going to happen to somebody, it's going to be this. I wouldn't go testing for this weird deficiency, right? But like just knowing that if it's going to happen to somebody, a 20-year-old female or classically a pregnant patient, that's where you'd observe it. And so absolutely fantastic to see improvement in the liver injury. Upsetting that there was other sequelae of the critical illness, but hopeful that this patient can make a long-term and excellent recovery.
Amazing case, and thanks so much, Dr. Tapper. And before I ask you to share your great teachings and then Raji as to why you chose the case, I'm just going to request Magnus to share one of the teaching pearls which he learned. And then Raji, then you could take us as to why you chose this case and what you learned from.
Yeah, thank you so much. Yeah, I think I would just like to share my favorite teaching point, which is that for acute liver injury, we should really let the context guide the workup. So, for example, hemochromatosis and Wilson's disease does not usually cause acute liver or does never cause acute liver failure, and that's why we should more be focused on other causes and examine the patient, see if we can find evidence for ischemic hepatitis, cholelithiasis, drug-induced or viral hepatitis. Thank you so much for our amazing discussion and case.
So things I learned along the way, I don't know. Everything that I'm saying, take it with a grain of salt because it's all like hindsight, reading about it. And basically, there are some case series that showed that if AST is very, very high compared to LDH, and the ratio of AST, sorry, the other way around, the LDH is greater than AST, and the ratio of the AST to LDH is less than 1, it is sometimes associated with HSV. Not sure. It's just based on case reports and case series where they report things. So it's based on a case series of 4 or 5 cases they put together, and they're trying to find out, especially in HSV and immunocompetent people. And they reported that in their case series, they found that AST is above 12,000 or like in the rated thousands. ALT is not that high, and the ratio of the AST to LDH was less than 1. And so, not sure, they don't have any data to back that up. It's basically an association that they saw. And the reason I chose this case is mainly it was a great learning opportunity for me in 3 different ways. One is never do early anchoring of diagnosis because we found ourselves anchoring on one thing after the other. So first, as soon as a patient came in, we were all like, it's Tylenol, it's toxic injury, delete, nothing else, everything is going to get better. And then after we got the rhabdo, the UA and everything, then we're like, oh, maybe it's not drug, it's just rhabdo, AST elevation. So prevent or resist yourself from early anchoring, keep yourself open because as data came in, we had to revise our diagnosis and improve. And second point is the diagnostic complexity because no patient will just present as textbook, right? Textbook is MRI shows us temporal lesions, HSV, like IgG is elevated or PCR is elevated, or the mucocutaneous lesions that you look for HSV. So every patient is different. They can pick and choose whatever they want and how to present. So that open-mindedness and this diagnostic complexity of slowly peeling it to get to the truth was extremely interesting to me. And finally, the overlapping syndrome, like sure, they can have multiple diagnoses. Not everything should be HSV related or everything should be rhabdo related. I think that was an eye opener to me that people can have as many diagnoses as they choose. I think those 3 things was like, this is the case I'm going to present.
Yeah,
That's
couldn't put it
fantastic.
any better than that. That's perfect summary.
Dr. Tapper, did you have any final words before we call it a day?
No, I think the final words are Raji's.
Humbled
Thank
as
you
usual.
so Thank you so much for everyone who could join us, and I wish you all a happy rest of the week and look forward to having Raji and Dr. Tepper soon again with us. Thank you. Bye-bye.